Hello, everyone, and welcome to our November edition of our free Q&A. You've got myself, Sherry Teague, and Cindy Krafft. Good afternoon, Cindy. How are you?
Pretty good. How are you doing today, Sherry?
I'm pretty good. I'm pretty good. Those of you that came on earlier may have seen some crazy closed captions going on. Got a call from my nephew, and many of you who have younger family members, when you get calls out of nowhere, you'll answer them to make sure everything's okay. So I apologize for anybody that may have overread, not overheard, but overread some of that conversation before I could step away. This is our last session this year, Cindy. Can you believe it?
I can't believe we're nearly done with 2023.
It's been a crazy few years. So in honor of our last session and in honor of you wonderful people who signed up to join us on this adventure, we wanted to ask you guys some questions first off. Cindy, are we ready to start and open our poll?
Well, yeah, Sherry, because as Sherry and I were preparing for this one, I got to thinking about the questions I get asked directly via email, and then some recent events I've been able to participate in. And I thought, it's been a good model this way to have the questions ahead of time and answer those for you guys, and then you have the option to type in. But we wanted to try something a little bit different. So we've created 5 polling questions. I'm not sure we're going to do all 5. We'll kind of see how this goes today. But I wanted to be able to essentially ask you guys a question as a group, give you a chance to use the polling option to answer, and then we can kind of talk about not only the response issue, but some issues related to that. So kind of teeing it up that way. And we want feedback on this. By the time this session is over, if you say, yuck, I don't like that, please don't do polling anymore, feel free. We also know that for folks that are listening to the recorded version, you can't participate in the poll, but please don't just stop listening. We're going to have good discussion based on the results of each of the questions. So Sherry, tee up the first one.
Okay, everybody, you get 3 minutes to read and answer the question. So here we go. Tick tock, tick tock. In the meantime, Cindy, we can talk about what's going to happen with this Q&A going forward. We've decided that we're going to continue this Q&A every couple of months and try and get as many free items out to you guys in the new year. And Cindy, did you have anything else that you wanted to talk about while they were answering? I see answers pouring in.
That's good. We wanted to get engagement and be able to kind of, again, look at maybe changing the format up a little bit in 2024. So polling might be it, but if you guys have other ideas or thoughts about that, we'd love to get your feedback on this session, what works, what doesn't work, what you'd like to see in it, because we want to keep it interesting and engaging for the folks that are participating.
Absolutely. And we decided this year that we were going to go 100% virtual. And it was an interesting gamble to do that and not go to the rubber chicken tour. But we feel like we've been able to reach more folks and assist more agencies through our virtual platforms. So look for us to innovate even more in 2024 and try and get as much information as we can into the hands of agencies at a very reasonable price. And we're open to ideas, right, Sydney? Mm-hmm. We love to hear what it is that you guys feel is your most important thing. And I think probably most of you, we should have asked that question, Cindy, because most of them would probably say hiring at this point, if I had to guess.
So on the next question, Sherry, is it possible to shorten the time? Because
absolutely.
Okay, 3 minutes, people are going, that's a lot longer than I thought, and nobody wants to hear me like sing to fill airtime. So I can't see how many are still answering, Sherry. So if it's slowing down or done, we can close it sooner.
Yeah, I'm going to go ahead and close this one, Cindy, because it's leveled off. We've gotten all but 44 participants done. So I'm going to go ahead and close this poll so we can see the results. I hope we can see the results. I'm not sure how you do that.
Okay. Yep. I can see it in the same box.
Okay.
What the polling question was. So just to make sure everybody's on the same page, because I can't see the whole question now in that box. That first question was, what percentage of providers access their HHVBP interim reports for October in the first month after it was released? So we see that, there's a mixed bag. There's a few of you who lean toward over 90%. And my guess is if you chose that response, the four of you that did, actually you are the ones that pulled it off and may have somebody in your agency who's currently sleeping with it under their pillow. That indicates a high level of engagement in looking at those reports. But the correct answer, in fact, Sherry, is response A, less than 30%.
Wow.
How do we know this? I have the opportunity to have been selected for the newly started technical expert panel about the home health value-based purchasing expansion. And over the course of several of those meetings, there was a concern raised by the Medicare contractor trying to determine from the group why we thought that less than 30% had accessed them by the time we had had the meeting. So about a month had passed since it dropped, and they were not understanding why providers were not more engaged. And so I think it's something for us to really think about. Now, that number may have changed. I mean, more people have likely accessed it since. But I think part of the challenge is for those of you who have looked at yours, and I would imagine that a high percentage of folks engaged in these Q&As have looked at it. I personally think it's a tad confusing. There's a lot of information on it, and this data point comes from this timeline, and this date range is for this other thing. But I think to the agencies that aren't looking at it at all, there's definitely a risk there. And kind of the whole, we'll just do what we do and the chips fall where they may, that kind of financial implication, and many, who have run their calculations and contracted with folks to look at what those financial implications might be, may say, less than 1% swing of I got more or got less may not affect me as much depending on the size of my agency. But we strongly encourage at K&K that those reports are looked at. But they're also looked at realistically. We have to remember two key things, and Sherry and I were talking about it earlier this week. This has some overlap with respect to the whole issue we've been dealing with for a while now, which is our star ratings. So the issue for both of them, both the star ratings model and in value-based purchasing, is there's going to be winners and losers to balance it out. So for stars, this idea that if I'm a 3-star and if I work hard enough, I have a very clear path to be a 5-star is not how the program really works. And I think part of the problem there has been the fact that they chose stars as the icon. Because if I'm a restaurant and I want more stars, I can change my menu, update my decor, hire better servers, whatever I do, and then people will say, wow, that's really good, and I can work my way up against the standard of public opinion to get to a 5. That's not what we're doing here in home health. They take those measures and essentially run them through a bell curve. It does still contain the disclaimer on the front page, if you go to the website, that the majority of agencies will end up at a 3 or a 3.5 star. That's by intention. So there will always be people at the low end and at the high end, but it's all meant to balance it. So if everybody at the exact same time is working on the same thing equally as hard, you could still find yourself with the same stars you had before. I am not saying that as a just don't care, it doesn't matter thing. I mean, we do need to be working on the quality of our care. But I've been getting a lot of inquiries lately about, well, I'm a this star and I'm going to be that star. I'm not saying you can't be, but we have to be very cognizant of that model. Same is true with value-based purchasing. This is budget neutral. So it is intended that for anybody who ends up getting a little, they got to take it from somebody else. It's not like CMS has a big pot of money and is going to reward people across the board for their performance. That's old saying, Sherry, you're going to rob Peter to pay Paul here. So again, not a doom and gloom, not a don't work on it. But I just don't want to see agencies get themselves all worked up about I worked so hard and ended up with just this. That might be how the math worked. So I just, Sherry, do you have any thoughts on that? Because I'm just very concerned that with this diligence, that if I just do these 3 things, I can fix it, may not be realistic if I don't understand the full context of how the math of the model works.
Yeah, and I'm glad that we have 114 folks on this Q&A today, Cindy, because those are 114 souls that will help us advocate for this to be worked out in the provider's favor. We're getting fired up about this, and we're getting fired up in a kind of slow burn on at K&K, because when we look at the number of stars that an agency has, there's certain things that you would expect to see in an agency that maybe has 4 or 5 stars that we are seeing, that we're not seeing. We're seeing almost a complete disconnect between the stars and what's going on in an agency. We've seen some agencies with some very low stars that are doing things very well. And it just doesn't make any kind of boots on the ground sense at this point. So we're actually trying to find out more information about how the math works, and trying to figure out, how we can relay that information to our subscribers and to the folks that listen to us, but also maybe advocate for a better system. Again, I'll echo what Cindy said about the stars thing. The stars are actually very misleading. When we use that on Google, or if we use that on any of the other review sources, we can be pretty comfortable that if it gets the majority of 5 stars, that it's a quality product, right? We just hope that that can come true for home health agencies as well. But we're seeing some distinct inconsistencies, and that's a little bit troubling. And somebody
and Sherry, it's not just us. I mean, that recent issue that came out about the reporting of falls with major injury, and that whole discussion that for Medicare about how major falls with major injury is being underreported when they looked at claims data versus OASIS data, and then to put in there explicitly that there appeared to be a correlation between higher stars and lower reporting.
right.
So there are some concerns that these can be manipulated as well. So again, I mean, I just want to clarify, Sherry, we're not saying it doesn't matter, don't worry about it, don't work on it. I just know some souls that are really passionate that if they just do these 3 things, they're guaranteeing they're going to move their stars. I think we have to have just a touch of realism in it to keep doing our best for our patients, but also working toward, is there a better way to measure our quality than this?
100%. And we had somebody put in the chat that they've been hearing that less than 5% will be at the star rating. Yes, the lower percentage will be at the end of a bell curve. The majority will fall in the middle. And if you have referral sources that are telling you they can't refer to you because you're a 3-star agency, you need to give them the information that you have and anything at your disposal to explain to them that this does not work like star ratings that we see on Yelp for restaurants, or on Google for different things. That this is not that type of measure, and so you need to educate your providers so that they're not looking for that elusive 5-star agency, because if they only refer to 5 and 4-star agencies, there's not nearly enough of them to take care of the populace anyway. So just stay tuned for that, and hopefully we can employ some of y'all to get fired up with us if the time comes that there needs to be a little bit of activism around this. The next
suggestion, though, well, 1 second though, Sherry, my taking, going, I don't mean to talk over you, but whenever we get together, we tend to start, getting other ideas. I think along those lines, if we're dealing with a referral source who's arguing it can only be 4 or better, I would pull the information right off the Care Compare website that talks about the fact that the majority are 3 to 3.5, so that they understand that you're not saying that as some sort of excuse in their mind, that you're not trying, just to understand that this is how it's measured, and to have an external source that's CMS, as to why the math is what it is.
Exactly. And make sure that you guys are informing them all the time of what those things mean. And as a reminder, please, if you have any questions that pop up during our session today, pop them into the chat box or the Q&A box, and we'll get to as many of those as we can. But Cindy, are you ready for the second poll question?
Well, I want to tee up the second one. If we're going to be talking about quality and measures and value-based purchasing, I've been getting a question around this topic now with such regularity in the last few weeks. I basically created a cut and paste response. So I wanted to write a scenario just to see what you guys thought. So go ahead and tee up the next one, Sherry, and I'm going to read it when it first comes up, as folks answer the question.
Okay, I'm opening it now. I've got it set for 2 minutes this time, and we have 118 folks on with us. So get to answering, folks. Here we go.
Okay. So where is this? I can't get it to come up. I got it. A patient can ambulate safely and independently on all surfaces in their environment using a walker. The correct response to M1860 ambulation would be, pick your response. I think a lot of this, Sherry, has been coming from, as we deal with outcome measures, there's always this, we need to make sure that the OASIS is correct. And you and I both know that K&K's, one of our big mantras is accuracy and compliance above all else. And so there's been some interesting strategies suggested that we have to make sure we're always following what the guidance tells us with respect to choosing the best response. But I think within the ambulation question, it gets attention because there's reimbursement implications. It gets attention because of it's in the star ratings, it's in Care Compare, it's currently in the total normative composite elements of value-based purchasing. And it's also not a brand new question. So it seems that mastery of this should be easy and put to bed a long time ago, but it still does not seem to be. So I'm anxious to see what our polling results say about a patient in this situation.
30 seconds to go. I think 2 minutes might be our sweet spot. Ooh, we have somebody that says, oh, we got some discussions going on in the chat box. So read the chat box. I like it. I like it. I like it. Ten seconds. I feel like those shows 5 seconds.
If we keep this up, Sherry, we may just come up, if people like this, we might need some music interlude that can
Somebody
play
asked how
while
they
they're
can change
answering.
their answer. Once you pick your answer, I don't know if you can change it. So there we go. We're new to this polling thing, so bear with us. All right, Cindy, it's closed and the results are up.
Okay, so we have the response options. We know them very well. A 0 says you're completely safe and able. Nobody picked that, and that's good because to be a 0, a person, it clearly states they require no human assistance and no device. So that one would be off the table.
Cindy, I'm going to jump in there. We did have 3 folks that chose that answer. And
Okay.
I want to interject here. If you choose that answer, you need to immediately ask yourself a question. Are they homebound?
Well, in this case, that would be a secondary question to ask. The problem is, Sherry, I can't really see the bar graph very well, so I'm going to look at the numbers next to it. So yes, to the 3 folks that put it, the reason that we cannot use response 0 is, in fact, it states no human assistance and no equipment. And we said that this individual was completely safe and able and using a walker. So we cannot use response 0. We do see some that chose response 2. 71, the most popular answer was response 2. Well, let's look at response 2. Response 2, I know, starts with requires use of a 2-handed device to walk alone, but it does say and or requires human supervision or assistance to negotiate stairs or steps or uneven surfaces. So the issue being that there is an element of human assistance associated with response 2. Despite what's worded in the response, when we go to the official guidance, it very clearly says that when you're choosing between response 2 and 3, the type of equipment is irrelevant. The presence of equipment is irrelevant. The issue is, does someone need intermittent assistance, which is a 2, or continuous assistance, which is a 3? Well, we just said we have somebody with a walker walking all around in their environment with no need of assistance. So if there is no need of assistance, that doesn't really fit with response 2 or response 3. So by process of elimination, the only response that indicates someone is fully safe and able with equipment is response 1, which 6 of you picked. Now, I'm sure if we had live discussion open, I might have people hollering at me or arguing with me or telling me I don't see that in the manual. Okay, I'm a full disclaimer. Many of you have participated in several of these Q&A sessions, and you know me full well that I'm a big stickler on the guidance. In this case, we're forced into a process of elimination situation because, again, we're seeing the question. If you go back and look at the guidance, it clearly talks about when you're choosing between a 2 and a 3, it's the issue of, is the assistance required intermittent or continuous? So I am more than happy to take that on, to officially put that into a Q&A if somebody else already hasn't beat me to it, for clarification. And if CMS comes back and tells me I'm nuts, I will take it back. But as much as I've stared at this, I don't see how somebody completely safe and able in their environment with a walker would end up being a 2. So when we look at that issue, I think there has been so much confusion. And I know people are putting in it didn't say if they had stairs or not. The issue is safe and able in their environment. They are not required to have stairs. So stairs may be in their environment, they may not be. That's not a requirement of the item. And my issue here is that, okay, hold on. The scenario reads the patient is independent with a 2-wheeled walker. It doesn't say a wheeled walker. So this is where, again, I did this on purpose because I wanted to provoke some thought and conversation within agencies, because this can be a very serious issue at the time of discharge. Because I may have a patient who is now running all over their environment with this walker. If I keep going at looking at it says walker in 2, you are always a 2, then we may be limiting our ability to honestly, and I'm going to say that word again, Sherry, honestly show that this patient has improved to that point. Think about it this way. The bathing response options, in essence, lay out exactly the same as these. 0 or 1 in bathing is completely safe and able bather. The only difference between a 0 or a 1 is the presence of equipment. 0 doesn't need it, 1 does. Either way, they're magnificent, safe and able bathers. So the issue of bathing equipment doesn't say, did you use a tub seat or a transfer bench? Oh my gosh, if it's a transfer bench, you needed more help than a tub seat. No, it says if you needed equipment, but you're completely glorious doing it, you're a 1. So here, I believe the verbiage of cane is a 1 and walker is a 2 has misled us in terms of trying to figure out where to put that completely safe and able person with their walker, particularly at discharge, when we're saying they don't need our services anymore. So I'm not surprised at the distribution here. I have advocated to say to CMS, can we please fix the wording? Because if your own guidance says basically that the equipment is irrelevant, the type of equipment is irrelevant, then why does the question seem to say cane is a 1 and walker is a 2? The reason they don't change these questions, the ones in particular in the functional section, you notice nothing was touched going to OASIS E. That's because this question is in PDGM. It was in the prospective payment system before, it's in PDGM now. And they're concerned by changing anything in a payment related question is it could impact point calculation for payment going forward. So they keep trying to fix this through guidance, but I think it still causes confusion when you read literally our response options. So I have seen, bouncing back and forth here in the chat. I'm glad to see this level of engagement. I'm happy to do additional follow-up and we can talk about this again on another Q&A. But I just feel we've got to honestly look at this and say, if you lay the bathing question next to the ambulation question and look at the ambulation guidance with respect to clarifying those pieces of equipment, then I believe that a person who's completely safe and able in every aspect of their environment, going around with a walker, is on the same response level as someone running all around with a cane. They're still using equipment, but they're not using anybody.
And I think that somebody just asked, please, let's have some additional follow-up. I think the biggest confusion is the one-handed versus two-handed, and the assumption that this particular type of walker in this scenario is a two-handed device, because it could be a one-handed device, or they could comfortably release one hand from the walker, like you said, to have it available for other things. and comfortably, I say independently and safely, as comfortably. That's my definition of that, Cindy. So that is a very confusing one, and obviously we could probably do a podcast on just this one item. But I would point people to some of the things that we already have in our litany of information in the quarterly operationalizing Oasis for quarter. Which one did you do function, Cindy? Was that quarter 3?
I believe so.
Yeah. So look on our website for that kind of thing. And thank you guys for these questions. This is great because this assists us in creating the information that you need to hear. Now, so my next question, do we want to go to the poll, or can I ask a question that came in the other day?
Go ahead.
Okay. So the question is, starter care clinician did not do skin assessment on starter care per patient's refusal. On day 3, the PT performed a skin assessment and found a stage 2 pressure ulcer. Since it is in the 5-day window and the Oasis e-guidance manual states, when assessing clinician is unable to complete a full skin assessment at the first visit, the assessing clinician may collaborate with a second clinician. Could the pressure ulcer be captured on the starter care Oasis in the coding?
The short answer is yes. But I want us to be really careful in that, because that is yes in the context of that scenario as described. So the admitting clinician went out, the patient absolutely refused to let them do a skin assessment. That is not what we don't want to say is, oh, if the admitting clinician doesn't want to do the skin assessment, they can turf it to somebody else who's going out in the first 5 days. That's not what we're talking about. So an attempt was made. We could not do it on that first visit. Within the 5-day window, another discipline qualified to choose responses to that item does do that assessment and does find it. That does meet the criteria of collaboration within that 5-day window.
And I want to be really clear here for the coders that are listening here. If they quote unquote found a pressure ulcer,
Right.
that means that we probably do not have orders to treat that pressure ulcer, nor is the etiology explained in the referral documentation. So that's your first step. You need to communicate with the physician that you found a wound and what stage you believe the wound is, but you should not lead the physician into thinking it's a pressure ulcer. You need to ask them what the etiology of that wound is. And I'm going to just say that, a lot of folks would want to put this in position 1 with their coding because of the implications for reimbursement. I would be very careful putting a stage 2 wound in the first position, unless that is the only reason that you're in the house. There could be other things that you're there to focus on, and you do not want to look like you're trying to upcode by placing a wound that doesn't require a whole lot of intervention in that number 1 position. Any other statement on that, Cindy?
Nope.
Okay. Another question that came up this week, and you guys, please, if you have any other questions, put them into the chat and hit me directly if I miss one. This one was really interesting to me, Cindy, because it talks about agency processes a little bit. If a clinician leaves a piece of equipment or a personal item, say a jacket, a bag, or something of that nature in a patient's home, what should they do if they return to get that item and they find out that a family member took it out of the house?
I would defer that to you as a former agency owner.
I found this interesting because this is an occurrence. Those of you that have to deal with occurrence and incident reports, this is absolutely an occurrence on an agency level. If you return to the home and pick up your item, fine, hunky dory, no occurrence. It was a simple mistake. But if you return and find that has left the home where you left it, then it becomes an occurrence, and honestly, it's theft at that point. As a clinician, you should return that to your agency. The agency should do an occurrence report, and any documentation or any requests from the patient at that point or the patient's caregivers at that point should be done in writing. I think that it's an opportunity to use the systems that are in place in home health to decrease the risk of the agency, because if you don't have a trail and you're trying to recoup either the cost of an item that was taken from a clinician or you're trying to recoup that item, you could be, think about he said, she said. You don't want to get into a situation where the clinician or where the patient or the patient's family is saying that you're trying to harass somebody for an item that was left in the home. So I really encourage folks, decrease your risk, keep that in writing, and encourage your clinicians to come back to you should that happen. But I thought that was a really interesting question because, we're seeing some crazy stuff in the house. We're seeing some safety issues in the house. But, a lot of times we have processes that are in place to take care of these things. We just need to use those processes. Anything else?
Nope.
Okay. Okay. Now, do you want to go to another poll question or do you want to go to another question? Dealer's choice.
Well, let's go to another poll question.
Okay. Which poll question would you like for me to put up next? And is everybody ready for the next poll question? Somebody said their brain hurts and I'm scared.
Okay. Let's go with the third one.
Okay. Everybody ready to answer? Everybody got their pointing button ready or their pointing finger ready? Here we go. We got 2 minutes to answer this one. Go ahead, Cindy, read it.
So when completing upper body dressing, the clinician determines that the patient needs moderate physical assistance and verbal cues with undergarments, pulling on a shirt and buttoning a shirt, and is independent with zipping up their sweater. So what is the correct response to M1810 upper body dressing?
Ooh. I need my Jeopardy music.
That might be what we choose.
That was probably horribly off tune. I'm just warming up for all my hymns coming up the next month.
Hard to believe. I mean, with all the Christmas stuff visible right now, though, it's still hard to believe it's the 30th of November.
I know.
There was still another week in November in there that with Thanksgiving being early, it just felt off.
Yeah, and I have such empathy for what agencies are ramping up towards. They've already been through the beginning of the onslaught at Thanksgiving, but now going into the holiday season, it's a tough time for home health agencies. So, just as that song, I forget which of the holiday classics it's in, is just put one foot in front of the other.
Santa Claus is coming to town.
Thank you. Is that with Meister Burger?
Yes.
All right, that's one of my favorites. Rudolph is the all-time favorite. But
so we still getting responses, Sherry, or?
We are still getting responses.
Okay.
I think people are more hesitant. This is a anonymous poll, by the way. So please don't think that anybody's name is getting up there.
Yeah, we're not making secret lists out of it.
Oh, no. You're naughty or nice. You guys are all home health providers, so you're all on a nice list as far as I'm concerned. We have 3 seconds, 2 seconds, 1 second, last second. Okay, here we go. Poll results, Cindy.
All right, gotta scoot my screen over. I can't quite see in that one corner. Okay, so what we have to look at is this is an item subject to majority of task. And so when we look at majority of task, that means what level of assistance do they need for most of the task. And so when we look at our response options, we see that no one selected 0. So clearly this individual is not capable of getting out their clothing, putting them on and removing them without assistance. We did have some responses with respect to it being a 1. A 1, we have to remember when we deal with this question or lower body dressing or toileting, hygiene, or grooming, because all 4 of those answers have a similar pattern. Response 1 still means this person is completely safe and able at the act of dressing. All we've done with the response 1 is say that they can't gather it. They can't go get it from where it's kept. Well, that doesn't fit because this person needs significant amount of assistance. I want to skip C for a minute because we do have 14 people that went with D. Patient depends entirely upon another person to dress the upper body. Now, what we have to be careful of is majority of task is just that. So when we look at the majority of this, yes, they did need moderate physical assistance and verbal cues, but with the zippering part, they were independent, but that means they need moderate physical assistance and verbal cues with the rest of it. That would put them at response 2, not response 3. And the reason I put this question together, and I believe we touched on some of this in a previous Q&A, is there's some discussion going on now that's trying to say that majority of task really means that if you need any sort of help with the majority of task, then that, if it's the majority of the elements, that makes you dependent. That is not what the official guidance says. And my disclaimer to this is whoever is insisting that majority of task is leading people to mark dependent more often, I would ask for the source document. And I have on numerous occasions asked for the source document, and no one has been able to produce one. So I know several of you have asked for the source document with respect to ambulation. So I will be pulling something together in the next few days, Sherry, that you can put on our website to be able to address this. But in this case, the correct response is, in fact, as 68 of you put, response 2. Someone is helping. That did not indicate in the scenario that the patient could not participate in any meaningful way. Moderate assistance and verbal cues does not mean they're dependent. So 2 would be the correct answer. So although I probably spooked people with the previous question, I just wanted to touch on this, Sherry, from an outcomes perspective, to not fall into, well, if we put all this way, then we can score more people dependent at the beginning, and that gives us more room for outcomes. CMS does track our historical information, and they have noticed, thank you, every time they talk about the behavioral adjustment, how certain questions over time, somehow patients get worse on the heels of a reimbursement change, on the heels of an outcome measure change. So we have to be very careful that any change we're making or what we're teaching our staff to do with these questions does follow the official guidance.
And I want to say thank you to everyone who's answering these questions, even though we're making brains hurt, which that's correct. That's going to make me laugh for the rest of the day. So thank you for saying that. And as a thank you, we've opened up an online a cyber code that we want you guys to take advantage of. Anything that's online on our website is 20% off until the 31st of this year, to the end of the year. And you just apply that code at your checkout and get the 20% off. So I'll leave that up for a little bit. So folks that want to take a picture of this slide or copy it, they can. But, we appreciate you guys. We have 118 folks on this, and all but 20 answered that question, Cindy. So that's kind of fabulous. And we had a question come in that I'll jump in here real quick and ask, because I think it's a super pertinent question. How are agencies handling the delay with Medicare replacement prior authorizations? Most have 14 days before they have to make a decision. Okay, so Medicare Advantage, quote unquote, Medicare replacement. I don't know about you guys. I live in Florida, and some people would refer to Florida as God's waiting room, which is a little bit crass, but it is funny at the same time. And we are inundated daily to the tune of 20 plus commercials and advertisements and radio spots about, do you have Part A and Part B Medicare? You might be eligible for Part C, but they leave out the part about Part C replaces the A and B. And then once you go on Part C, I want to make it clear to everybody that once someone chooses Part C and they go on to a Medicare Advantage plan, they no longer have automatic acceptance to a secondary insurance. So getting off of a Medicare replacement plan is nearly impossible for folks that are over the age of 65 and have multiple comorbidities, or any comorbidities for that aspect. So making that choice is sometimes seems like the easier choice, but as we know, those of us that practice in this, we know that they don't get the same care on Medicare Part C as they do on A and B. And so encourage your patients to stay on traditional Medicare if you can. But Medicare replacements are now 50+% of the population. So we're all dealing with this pre-authorization. My recommendation, and agencies are handling this in a variety of ways. I mean, there's no consistent way that agencies are handling this, but as a former agency owner, I'm going to tell you one of the things that we did that seemed to help was that we did not wait until we needed visits to ask for authorizations. That sounds kind of counterproductive. Again, I'm going to say this: we did not wait until we needed visits to ask for authorizations. Oftentimes, when we got the referral for the start of care, we would immediately send a request for more visits with whatever documentation we have from the very first moment we get in contact with that patient. Now, are we going to use all those visits? Maybe, maybe not. but we wanted to get that ball rolling towards the authorization as soon as possible. And you can often do that if you look at the diagnosis list, if you look at the reason why that patient is coming to you. Many of you either use the technology algorithms or you have your own internal processes where you can kind of gauge how much assistance that these folks are going to need to have. And so start asking for those visits as soon as possible. And do not wait until the first authorization is over to request a second authorization. As you're starting to see that patient, maybe they gave you 5 visits to start. You get to visit 2 and you realize that 5 is not going to be enough. Go ahead and send that authorization off sooner rather than later. That to me was a semi-successful way of trying to stack those, or as we used to call it in outpatient therapy, dovetail the the authorizations, so that you're constantly closer to the time frames that the patient actually needs the care that you're getting the authorizations. Also, I wanted to mention I'm seeing a lot of information in my research where United Healthcare may be doing away with some of the prior authorization and the authorization processes that are currently in place. And those of you that look at the big picture of home health, United Healthcare just bought LHC, and they're in the process of buying Amedisys. It's under congressional review because that would give them a ginormous portion of the home health providers. But stay tuned to that kind of consolidation, because when the providers get involved, there could be some positives that come out to the community. And one of those, it looks like United is actually exploring doing away with their prior authorization requirements. Did I make that more confusing, Cindy?
I don't think so, Sherry. I think the frustration of this whole thing is very real. I know with open enrollment going on right now, that commercial with the Martha, the yelling old lady, they're trying to get her to buy, the Medicare Advantage is just ridiculous. But I think your advice is very helpful.
Okay. Any other questions on that? Feel free. When we get to the end of our slide deck here, we have our email addresses. And again, please put any information, any other questions that you have into the chat box. Someone mentioned that they tell everyone to get Medigap instead. And Cindy, folks are still on that 1860. So you've got another statement in the chat box towards that. So again, Cindy will put something together and get you guys that information so that the community can go down.
Okay, Sherry, what I want to say right now is please, because I never want to cause a problem. Well, sometimes good trouble, but this one, what I want folks to do is keep doing what you're doing right now. And I will put together what I can in relation to this issue. So please don't panic and don't get off this Q&A and off the recording and say, Cindy Krafft said, and this is what we're going to do starting tomorrow. No, take a breath. I want us to seriously think about this though, because what I'm seeing is a trend toward, well, if this is true, this can improve my outcomes better. I'm not sure it's that. It's more, are we baselining people correctly? As opposed to going down this rabbit hole and getting tied up in knots about what I said as food for thought, I want us to think about what the bigger issue is, which is what we find in our outsourcing program and nearly every single time I audit people's OASIS. That is, we seem to have an affinity toward putting 2 as the baseline. And once you do that, you have a very difficult time trying to determine how are we going to be able to show improvement. I've seen that come through on several of these chat boxes. That is something you can fix immediately. Mm-hmm. If we really think about these individuals, they are overwhelmingly coming to us from hospitals, from nursing homes, from rehab, or something happened in their lives that warranted a home health referral from the community. So something has happened to these people, okay, recently. They're coming to home health. In order to qualify for services, they have to be homebound. And overwhelmingly, we are documenting that these individuals at the start of care meet homebound criteria because of a mobility-related issue. Yes, sometimes it is about a physician restriction or whatever, but overwhelmingly, the documentation says it's mobility-related. And I have completed a fall risk assessment, and the patient has been identified in that assessment as at high risk for falls. So do we think someone who just got out of a facility or had a life event that warranted this referral is considered homebound and failed my fall risk assessment should be at least supervised in this day of the assessment, right where I am assessing in the 24 hours preceding? Should they be at least supervised? And overwhelmingly, clinicians will tell me yes. Well, if that's true, M1860 is a 3, not a 2.
Mhm.
And I think that is the bigger nugget now, as opposed to getting everybody riled up. Set that aside for a moment. Okay, it's been a rough week coming off of Thanksgiving, and we will turn back to this. Don't radically change your processes. But I think the missed opportunity is the issue of I see too many baselines at 2 because somebody had a walker. And I don't know, I can't be the only one that's tired of rereading the guidance to folks. The bottom line is you can just, you had an intervening life event that precipitated this referral. You are qualifying for services off of a mobility related issue, and you failed a fall risk assessment. If this was my grandma, would I want her at least supervised today? The time I'm here in the 24 hours preceding, I didn't say permanently. I didn't say, oh my gosh, they live alone and this is terrible. I'm saying at a minimum, would I want my grandma supervised? And if the answer is yes, you got to stop calling other people's grandmas too. To me, that is the bigger issue with respect to being able to show meaningful improvement, is not, oh my gosh, how do we work this in at the top end? Are we getting it right at the beginning? And I can say our number one correction area remains the functional assessment, M1860 coming in as a 2 because somebody had a walker at the very beginning. And a 2 does not indicate that you're saying, based on safety, whenever this person is up and walking the day of the assessment, my preference is that they would be at least supervised. So
Absolutely.
to me, that's the theme, Sherry, is I'm seeing a lot of this. Well, this would work. You know, if this is true, this works for out. Yes, but I believe the only way that that would be some magical solution for your outcome is if you're seeing a bunch of people start as 2s. And if they're starting a bunch of people as 2s, the issue is that needs to be revisited, not think, oh gosh, what I just said will fix it all because we can make them 1s at discharge.
Absolutely, absolutely. And you guys, this goes to a bigger issue in a lot of home health agencies. I'm going to echo what Cindy said about making drastic changes based on hearing something. Oftentimes we get folks that come into and use our services and they've heard a lot of things that they can't get verification of. And or they have some tough news to provide to their staff, but it's very difficult for them to do. Most of you that are on this call today, most of you that are on this webinar are leaders in your agency or leaders in your company at some level. And so we wanted to offer an opportunity to create what we have created, a leadership community. And that leadership community is going to begin on January 1st, 2024. And what it's going to be is it's going to be basically it's a leadership squad for home health. And so we want you to have the opportunity to learn how to manage change, how to manage people, how to retain the employees that you have, how to improve your leadership acumen. We have a special going on that is $79.99 for the year. During that year, you're going to receive all kinds of information that you're going to be able to take in virtually and use at your leisure, but also be able to access peers. Many times in home health, we compete against one another, but we do not learn from each other. So this is an opportunity to get with a like-minded group with a like-minded mission and have resources outside of your immediate sphere. You know, have folks that are great leaders be able to assist you in what you have to do in a home health agency. It's tough what you guys do in home health agencies. And so giving you the opportunity to improve your skills and to improve your satisfaction of your job is a great opportunity. So take advantage of this and make sure that we have that you guys get together and form this, and then maybe help with, you know, agencies that aren't in big, huge corporate structures feel like they have some resources that they can access easily. So if this is something that sings to you, please join, take advantage of this. It's $20 less now than it will be on January 1st. So take advantage of that. Cindy wants to go to another poll question because you know what? She's just a meanie. That's all I'm going to say.
Not a complete meanie, but this one shouldn't make too many brains hurt.
Okay, no brains hurting because we're getting towards the end. So if you have any other questions, there was another question about Medicare replacement. Please contact me offline. Please use my email address in the next slide and send me those questions, because I definitely have some ways that you can try to manipulate that system a little bit to assist you with those Medicare advantages. Okay, here we go. I'm opening the poll. 2 minutes. Are we ready? Hover your mouse and get ready to answer. Here we go.
Okay. As confirmed in the final rule for 2024, all of the following items will be included in the home health value-based purchasing calculations starting in 2025, baseline year 2023, except So 3 of the 4 will be in the value-based purchasing calculation going forward. 1 of them will not. So pick the one that is not going in to the change in the model. And as you and I have talked, Sherry, it's like, wow. So we barely are out of the gate. We're sort of trying to figure out our interim reports, at least, the few people that did look at them. And now they want to change it. And the change in terms of the measurement year is 2025, but that does in fact mean baseline year for the things that they changed is 2023. And when you let people know that in the end of 2023, then the 2023 baseline data is pretty much is what it is. The issue will be, okay, so what does that mean for us going forward? So to be clear, everything that they had put in the proposed rule with respect to value-based purchasing changes all happened exactly the way they laid it out. So there was considerable feedback about those changes, but I think it was very clear, and it was also clear on the TEP that minds had already been made up that these revisions needed to happen. And so that is what we're looking at as this program continues to unroll.
And Cindy, we may have time, and I hope we do have time we have 10 seconds left on this question, by the way, because one of your friends is poking the bear in the question Q&A box, and I want to get to that question for sure.
Okay.
Okay, here we go. The options for answering, somebody asked us to read those. Number 1 was A, GG0130, A, eating. B was GG0130B, oral hygiene. C was C, GG0130C, toileting hygiene. And D was GG0130E, shower, bathe, self.
Okay, so which one is not being included? Did you hit the results, Sherry? I don't see results.
Oh, I didn't hit apply. Sorry about that. As you guys can tell, this is the first time we've done this because I am slow on my buttons.
So we do know that even if we had just a very overview look at the proposed rule, it was made clear that they intend to move away from the M items related to function. So the M1800s would no longer be part of the calculation, and it's going to go to GG items. Now, many people went, oh, well, that's interesting. And some felt very good because GGs look at more tasks, and they also have a different scale that allows you to speak a bit differently about how much assistance someone needs. But what we have to understand is that they are not utilizing every one of GG130 and every one of GG170. They're using a subset, which is why I wrote this question, because the one that will not be part of the calculation is GG130E, shower, bathe, self. And only 11 folks selected that one correctly. Many folks felt eating wasn't going to be in it, oral hygiene wouldn't be in it, but they are. And if you look, and I strongly encourage you to do so, if you look at the listed items from GG130 and GG170 that are going to be in value-based purchasing, again, baseline year 2023, measurement year 2025, it's rather shocking. Why would bathing not be there? What else isn't there? Upper body dressing isn't there. Lower body dressing isn't there. Footwear isn't there. Why on earth would you not have those things in a home health measure? I can tell you why. Because the movement to GG and this discharge functional score is to align us further with other elements of post-acute care, skilled nursing facility, inpatient rehab, and long-term acute care hospitals. The issue is that the GG item set, GG130 and GG170, the entire list of them was not put into the LTACs. Now, which I get it. I mean, if you're in a long-term acute care hospital, I'm not assuming there's going to be a lot of movement on bigger activities like showering and dressing and so on and so forth. However, that tied the hands of the other settings in terms of if we have to use measures that are truly cross-setting for all four, then we cannot use ones that are not in the LTAC list. So this is going back to the beloved Impact Act of years ago, moving us toward these post-acute cross-setting measures that we are not getting the full set. And I can tell you, I was vocal in the comments, I was vocal on the TEP, that for our setting, when you're going to leave in rolling and leave out dressing, this is going to be interesting. Because a lot of our patients, being able to roll and sit up at the side of the bed and move from sit to stand is what you have to do to go home. Once you're home, those bigger functional issues that are more of a challenge because they're not in a contrived environment like a facility, they're in your home environment, are a bigger problem for them. They agree. However, it has to be measurement items that are across all four settings. So make sure you've looked to see what those are. Now, what does that mean? Oh, okay, if that's what's going in there, then I'm only going to work on the ones in the subset. Okay, no. We need to make sure that our responses to the GG items are what they should have been this entire time, that they are the most appropriate for the patient and that they align with what we've been putting in the 1800s. I'm shocked that there are still agencies that don't think there needs to be any relationship. They're focused on the 1800s and the GGs are just that thing over there and they don't match. I know they don't match, but they need to make sense. If you're saying someone needs assistance in the 1800s and then you go over to the GGs on a very similar task and put a 6 independent or 5 setup cleanup, that does not go together. Also, I caution because now I'm seeing people ever since that final rule drop, their quality plan is now we're going to focus on the GGs. So CMS already believes that we do interesting things with OASIS data. So if GGs have been sitting at a very long level of here's the information, and then all of a sudden, because it's going into value-based purchasing, our patients tank, and now nobody can roll, nobody can stand up, nobody can eat, nobody can do this, it's going to look rather obvious what happened. So yes, we need to make sure we're answering every question, every time point, every time to the best of our ability. And we need to make sure our GGs are in good shape. But we also need to plan accordingly that what it's going to measure may not be what we thought it was going to measure. Because I'm hearing even in the TEP itself, so well, we're not going to use GG 130 and GG 170. And I said, excuse me, you need to clarify. You're not using the whole thing. And the ones you've cut out have been interesting. So.
And I think that somebody put it in the chat box. I think the word harmony is a perfect word for the GG items to the 1800s. And one of the things I want to mention as we finish, I know a lot of folks have to go. We're up against 2 o'clock. Is I want to caution people to not worry so much about stabilization in the next year. That's one of the reasons why they went to the GGs, is they wanted to take away the feeling that providers had that stabilizing a patient and keeping them home safely was something that would not assist them as far as outcomes. Cindy, can you briefly talk about that as we finish up?
Can you repeat that, Sherry? I missed part of it.
About stabilizing, that they moved to the GG items on the yes. Discharge GG items, and that the thoughts have been historically that if we stabilize a patient, we do not get credit for them improving on the outcome side. Can you briefly explain how they've changed that in the new rule, that stabilization is actually it's always been a good thing, but stabilization is actually something that might be captured now?
Because what they're going to do is they're going to look at our baseline scoring of those subsets of GG 130 and GG 170. They're going to run it through a risk adjustment model to predict what the discharge value will be. We will not be predicting it. The goals column will be coming out of both of those items in 2025. And based on that, then the issue is, did you meet or exceed that projection? So if we look at comorbidities, we look at other questions in the risk adjustment model, and realistically, they're not expected to improve in all of these areas, then that would be the projection. And if we stabilize them or did some ultimately improve them, both would be considered a positive patient outcome. So it's not talking about improvement in the sense that we have to get everybody better. but it's, do we meet or exceed the projected expectation? Now, that could be a whole other conversation, Sherry, about using math to project it versus clinical judgment. But I kind of understand that when we see so many records where clinicians seem to like to put sixes of the patient's going to be completely independent in everything, all the time, everywhere, all at once. There's got to be something maybe better for that, but it is going to account for stabilization. It is not going to be solely focused on your ability to improve all of these areas. So
And
that
with
is a
that,
big win away from the everybody's got to fix everything.
exactly, and it hopefully will take away that incentive to underscore or overscore based on the payment items. To to have folks. The data needs to be cleaned up. The data needs to be true, and it needs to be what you're seeing in front of you versus some mechanically changed thing that trying to improve your reimbursement. That's a scary place to be. But as we finish, I want to wish everybody, you guys are all in home health, so I'm going to wish you a smooth, safe, happy holiday. And I hope that everything as you close out the year, that you guys have some peace and good time with good friends and family. And we will be here for you. If you need us, please save our email addresses and reach out and let us know. We're here to help. Cindy, do you have any closing thoughts?
Again, don't change what you're doing with 1860. More to come.
Those
I
of
don't
you
want, I don't want to be held responsible that Cindy Krafft said something that screwed a whole bunch of stuff up. So
Yep. Well, it'll be in our newsletter. So those of you that most of y'all subscribe to our newsletter, so make sure that you look for that item to be explained further in our upcoming newsletter. So thank y'all so much and happy holidays. Be safe.